Kia ora, everyone. Welcome today. It's my great pleasure to introduce Thomas, who I met whilst working in the AUT integrated data infrastructure. Thomas has been in New Zealand for 2 years, coming up to almost 3, originally from Austria, and my limited knowledge of Austria is actually largely around the sound of music and the beautiful scenery there. Thomas, however, was previously at the Department of Economics, and his areas of interest are health, family, and labour economics. And he has continued that passion with work on health and literacy and numeracy in New Zealand, and the fabulous work today that he'll be presenting on immunisation.
So thank you very much again. Thank you for the invitation. Thank you for the possibility to talk about my research here. The research I am talking about is the impact of the COVID-19 pandemic on childhood vaccine uptake. And it is joint work with Leon Iusitini and Gail Pacheco, who are also at the New Zealand Work Research Institute here at the AUT. And I should also add that this research was thankfully funded by a grant from the Ministry of Health, and it is part of a larger research project where there's also a qualitative component where colleagues talk with healthcare providers and parents about their vaccination attitudes and behavior during the pandemic. And also kind of the usual disclaimer applies when you're using IVI data that all mistakes are our own. So why is childhood vaccine uptake an important topic? Well, vaccinations are kind of a brilliant invention. They are in principle very cheap to produce and administer and can prevent a lot of illness. So they're often regarded as one of the most cost-effective interventions that has ever been explored. And from an economic point of view, there is this additional factor that there are externalities of immunization. So if I am immune to a disease, I cannot infect others. So this is an additional, I would say, reason why we need policies, or why it's a good idea to have policies that promote vaccine uptake, because we know from a lot of research that individuals don't take these kind of externalities into account when they make up their own decisions, what they should do. Even before the pandemic hit New Zealand and the world, there were already big gaps in uptake of childhood vaccines. So in the year leading up to the pandemic, there was for most groups that ethnic groups in New Zealand, uptake was well below the national target of 95% coverage. Only for Asian children, actually, it surpassed the target, but there were already large gaps in uptake for Māori children and Pacific children. Then, of course, the pandemic hit, and you can imagine a lot of potential channels how the pandemic could affect childhood vaccine uptake. First of all, of course, there was this big health scare at the beginning. Everybody was afraid of getting COVID, and this could, of course, affect individual behavior, family behavior. Second, the health system changed quite a bit. There was no focus of the healthcare workers on kind of pandemic responses. Third, there was then policy responses. There was the lockdown and travel restrictions. There were, for example, fewer public transport options available, and this could again affect uptake of childhood vaccines. Then there was also a lot of information and potentially misinformation out there on are childhood vaccines actually an essential service during the lockdowns? Is it okay if I go to the doctor and get get these kind of immunizations done. And of course, there's also kind of a general effect of parents' perception, because COVID itself is also an infectious disease. So it could be that just the presence of another pandemic could affect behavior. It could also affect it positively in terms of that people are now more aware that there are these kind of infectious diseases out there, and they might even think now, yeah, immunization for childhood diseases is a good idea. So I increase my uptake. In terms of the official guideline from the Ministry of Health, the idea was to keep vaccinating. There was kind of officially childhood immunizations were considered an essential service, and they were supposed to continue even during the strict lockdowns. And the healthcare providers were strongly encouraged to deliver immunization, especially the early ones for infants. So given all these potential different channels, how the pandemic could affect uptake, of course, the question is now, how did it affect uptake in the end? And this is where we want to contribute with our research. We're going to analyze immunization events for children below 5 years. And we're going to explore who missed their vaccines. And then we also want to follow these children and see if they manage to catch up missed vaccines over time. So we're going to look at the start of the pandemic, but then also follow children for 9 months to see if they manage to catch up in terms of vaccine uptake. Looking at the existing evidence, there is quite a lot out there, of course, given that the pandemic was kind of a worldwide thing. And the international literature seems to find mostly negative impacts at the start of the pandemic. So especially there are quite a lot of studies from the US which show that there are decreases in uptake of childhood vaccines, but there are also a couple of studies actually find positive impacts. There's for either for individual regions or for specific vaccine types. So empirically, it's not clear, and it is because, as I just said, there are potential different mechanisms that could affect uptake. In New Zealand, if you look at the aggregate uptake published by the Ministry of Health, you see immediately, yeah, there is a decrease in uptake of childhood immunization. There is kind of this time trend in the last couple of years that is, yeah, clearly visible when you look at the aggregate numbers. But we think there is little evidence on catch-up behavior and kind of heterogeneous impacts of the pandemic, and this is where we want to contribute. So how did the pandemic affect different population groups within New Zealand? And then also, how was the catch-up behavior? Did people, children who missed out timely vaccines, did they manage to catch up over time? The data that I'm going to use comes from the integrated data infrastructure. Most of you already know, I think. This is this population-wide research database managed by Statistics New Zealand. Holds microdata from different government agencies. For our research, important and central is the National Immunization Register, which holds data on the types of administered vaccines and the date when it was given. Then we use data on birth registrations from the Department of Internal Affairs to construct our population of interest. And then we also use additional data sources to explore these different population groups. So there is information on ethnicity and place of residence from the IDI central tables. Then we look at families with different earnings from inland revenue tax data. We do a little bit on looking at parents' education, and also we use the New Zealand deprivation index from 2018. If you just look at the raw data on given childhood vaccines over time, there is actually quite a lot going on. So here you see just the raw number of administered vaccines in a given month for children under the age of 5 years over the course of 7 years from 2015 to 2021. A couple of things that you note here immediately is, it's quite noisy, first of all. Second, there are like quite strong changes in time trends that come from changes in the immunization schedule. If you look at the black line, which is the varicella vaccine or the chickenpox vaccine, this was introduced into the schedule around 2017, and you see, of course, here an uptake in this vaccine, which wasn't provided earlier, or it was just provided to a selected group of children earlier. Then you can also see quite a big impact of the measles pandemic that New Zealand had in 2019, when there was these large spikes in uptake. If you look at the red line here, which is the measles, mumps, and rubella vaccine, there are these big increases in uptake during this measles outbreak, where there were like more than 2,000 cases of measles in New Zealand. If you go a little bit further to the start of the pandemic, then you see something. You see there are these kind of dips in uptake in April 2020, so right at the start of the pandemic, which are especially pronounced for the measles vaccine and for these other vaccines, maybe not as pronounced. And then you see also some kind of weird time trends during the course of the pandemic. You see there seems to be this big increase in MMR uptake in 21 and kind of a decrease in PCV uptake. These are, at least to a large extent, explained again by changes in the schedule, in the national immunization schedule, because the measles vaccine is now given earlier, and this of course resulted in a single month more children receiving the vaccine. And it was the other way around for the PCV vaccine, where there was the number of doses that you are supposed to receive was reduced by 1. And this is why we see this trend. At least this partly explains, we think, that this decrease in uptake. It's easier to see, I think, uptake if we then also kind of take the relevant population into account. And we do this by looking at the share of fully immunized children really within 1 month of becoming eligible for a specific vaccine. So if you look, for example, here at the specific, so we also look here now at the individual vaccination events or immunization events. So here, this pink line is the 4-year event. And if you consider here this first dot in January 2018, here we look at children who just got 4 years old in December 2017. So there was their birthday. They are now eligible to receive the immunizations for the 4-year event. 50% of them get them within January 2018. So within 1 month of becoming eligible. And you see a couple of things. You see like people or children or families seem to like get these later immunization events not as close as to becoming, not as close as they are eligible. So uptake here for this 4-year event is only around 50%, while for the early immunizations for the 6-week event, it's like close to 90%. But children also already received the vaccine within 1 month of becoming eligible. And in terms of time trends, you also see quite large differences between the immunization events. So there seems to be relatively, before the pandemic, flat time trends for these early immunization events, and then maybe a little bit of a decrease during the pandemic. And I think what's interesting is for these later immunization events, especially 4-year event, you see this big drop in timely uptake immediately at the start of the pandemic. So again, this is April 2020. And this kind of initial gaps at the start of the pandemic is kind of the focus of this research that I'm talking about today. So we're not really looking much about these decreases in trends that happen over the course of the pandemic in the maybe last 1.5 years. But we looked at these initial drops, and then we want to understand, did children who missed out on these kind of shots, did they manage to catch up? So, and how do we do this? We do this primarily in terms of a regression framework. And the idea is that we want to compare children who become eligible at the start of the pandemic, which we call affected children, with a control group of children who are unaffected by the pandemic. So the affected children, again, become eligible in these 3 months at the start of the pandemic. We want to compare their immunization uptake to an unaffected group of children who becomes eligible 1 year earlier and is also born 1 year earlier. So we then essentially compare the children at the same age, but at different times. In a regression framework, this means we regress the outcome if a child has received specific recommended vaccines at a particular age on an indicator if the child belongs to the affected group, yes or no. And then these betas give just the difference between the affected and the unaffected cohort of children. And of course, we can include an additional control variables to test kind of the sensitivity of the results. And then we estimate this equation at 9 different points in time for each immunization event. For example, for the 4-year event, we follow children from 49 months of age, so when they just became eligible to get the vaccine, until they are 57 months old, to see if they manage to catch up, basically, over time. The identifying assumption that is behind this idea is, of course, that we assume that the affected children would have behaved similarly if there was not a pandemic, which is, of course, untestable because, there was the pandemic everywhere. So it's still an assumption. What we can do is we can look at the observable characteristics of these two groups of children to see if they are like systematically different. And so far as we can say, it looks fine. If you don't like regression equations, here is the empirical approach graphically presented, which I think is easier to understand. So again, we have these two groups of children: the affected cohort, which was hit by the pandemic, and the earlier one cohort in blue, which was not affected. And we follow the same children from the time they become eligible until, and then over the course of 9 months. And here is kind of the share of fully immunized children depicted. By definition, for both groups of children, the number of children who are fully immunized at the 4-year event increases over time. But you can see also differences in the share of fully immunized children. So the non-affected children, which we observed kind of before the pandemic, at 49 months, they had 60% of them were fully immunized, where it was only around 45% for the affected group. This difference of about 15 percentage points, we then just say, yeah, this is probably likely caused by the pandemic. Then over the course of the pandemic, we see that both groups, as I said, increase their the share of fully immunized children, but the affected cohort, they catch up at least to some extent. The share of fully immunized children increases by more, and at 57 months of age, the difference is much smaller. I think 7 percentage points here in this picture. So that there was some catch-up behavior over the course of the pandemic. And what I'm interested in and what I will show from now on is basically the difference between these two lines. So the difference in immunization uptake between the affected cohort and the not affected cohort, which we say is the effect of the pandemic on childhood vaccine uptake. And these are the kind of average effects for these individual immunization events. So again, maybe looking first at the 4-year event in pink, at the when they are like 1 month after they become eligible. So for this event, when they are 49 months old, there is a difference of 15 percentage points in uptake. So the pandemic led to a reduction in fully immunized children of 50 percentage points for this immunization event at the start of the pandemic. And then you see this catch-up behavior here over time, and 9 months later, there was still a gap of 6 percentage points in uptake for these 4-year units. And kind of consistently with the pictures I have shown you already, most of the action that we observed in this at the start of the pandemic was happening for these 4 years. There is also at least statistically significant decrease in uptake for the 15 months event, around 3 percentage points. But then these families managed to catch up, and after 9 months, there is no statistically significant difference visible. And for these immunization events that happen even earlier for younger children, we don't see, for most of them, we don't see any statistically significant effect on uptake. I think what's interesting is then when we look at different subpopulations. So we run then these regressions that I explained for different groups of the population to see if the pandemic had different effects on different people. And here you see the results by ethnicity, and I again will focus from now on the 4-year event because there was not a lot happening for these other events. And you see quite an interesting pattern. You see at the start of the pandemic, there was big effects for all ethnic groups. Effects were even a little bit bigger for European children. But then there was a big difference in uptake. So children with European or Asian ethnicity managed to catch up almost fully. There's only, I think, 2 to 4 percentage point reduction in uptake at 57 months of age. In contrast, when you look at effects for Māori or Pacific people children, you see no catch-up basically. So there is a similar effect at the start of the pandemic, but even 9 months later, there is still this big difference. So they didn't manage to catch up. He's missed out vaccinations for time. And of course, this is quite concerning because these groups had already, before the pandemic hit, lower immunization uptake than European or Asian children. So at 57 months of age, even before the pandemic, Māori and Pacific children had 13 or 6 percentage points lower uptake, and this gap just increased now additionally. So this is kind of the one of the findings is that the pandemic therefore led to a widening of the existing inequalities in childhood immunization. Then we look at additional characteristics of children. We see also large differences in catch-up behavior related to birth order, where we see that third or fourth born children manage to catch up way slower compared to earlier born children. This kind of connects to a larger literature on the effects of birth order. I have a paper on uptake, childhood immunization uptake related to birth order with data from Austria, and there we find similar effects, that there are large differences. Parents struggle to immunize their children on time for these higher birth orders. And we find similar patterns here, and we also find that catch-up behavior differs quite a bit. We don't find any differences between boys and girls. Just to summarize, for these other immunization events, again, we see smaller effects. When we see effects, they seem to be more persistent for children with Māori or Pacific ethnicity. So this confirms the results for the 4-year events, but at a smaller magnitude. When you look at earnings, you similarly see quite different results. Again, at the start of the pandemic, quite similar results, quite similar effects for these three groups. So what we did here is we split the family earnings into approximately 3 equally sized groups based on the main earner of the family. And you see for the high earnings families, catch-up was fastest. So they almost managed to catch up. Well, the difference is still 4 percentage points, so there is still an effect of the pandemic. But interestingly, the catch-up was way slower for low earnings families. So again, difference in catch-up behavior for these different population groups. And this holds also when we look at different socioeconomic characteristics. So we also looked at parents' education level and their welfare benefit received. And it seems that there's always this pattern that there's less or no catch-up for children from lower socioeconomic status families. You also see interesting difference in terms of the marital status of the parents. There are longer lasting effects of children with unmarried parents. This could plausibly be connected to sole parenting. Those who are not married are likely more often sole parents and probably then have lower parental resources in terms of money, but also time. And this could explain these differences in effects. Lastly, we looked at the differences with respect to where people live. And it's a little bit a different type of presentation. you see again the 4-year immunization event, but the effects are now these kind of bars. The blue bars is the effect for the effect of the pandemic at 49 months, and the green bar at 57 months. When you compare the bars, you see the green bar is smaller than the blue bar for all regions, which means there was catch-up behavior across New Zealand, which is good. But there were quite, there are sizable differences. So if you just look at the green bars at 57 months, you see that there are still large differences, large effects of the pandemic, especially in Waikato and in Northland, and also in Gisborne. So these are kind of still persistent effects, whereas for other regions there is almost no effect or no statistically significant effect that happened. Of course, we can only speculate a little bit what could explain this. There are, of course, people with different characteristics live in different regions. So again, this could be connected to, for example, different ethnicities living in Northland compared to other parts of New Zealand, or it could also be a different experience of the pandemic. Of course, Auckland had these longer lockdowns. This could affect catch-up behavior of people around the North Island differently than in other regions of New Zealand. And when we look at the area level of deprivation, we find quite similar results when we compare to when we measure socioeconomic status at the family level. Again, we find this slower catch-up for families living in high deprivation areas. This is consistent with our results when we measure family earnings at the family level. So to conclude, we see these kind of small or zero effects on timely immunization at these early events for infants, but we see these large effects at the start of the pandemic for these 4 years. We see them across population groups, but we see significant differences in catch-up than when we follow the children. And these gaps that are there for everybody, they seem to reduce for many children, but they seem to remain quite large for Māori and Pacific children and children from low socioeconomic status families, which, as I said, looking at uptake before the pandemic means the pre-existing inequalities increase. Why do we see these patterns? Here I kind of have to leave the things that we can do with our admin data and look at what other international researchers or our colleagues who interviewed healthcare providers and families, what they found. And there is, of course, evidence that parents had different motivations. They did not wish to burden the healthcare providers, and they had this fear of COVID exposure, and this led them to not take up immunizations. And in New Zealand, there was also this uncertainty, at least among some people, that whether this routine childhood vaccinations were an essential service. Why were these differences between immunization events? This could also be related to different factors. Maybe it's because parents have different priorities themselves. They think they have more time to catch up in later immunizations. But it could also be driven by healthcare providers, because the Ministry of Health said that they should prioritize these early childhood immunizations and focus on them. And this could also explain why we see these differences between events. Why we see these ethnic differences could also be explained by different factors. We know from other research that families with Māori or Pacific people ethnicity they were often hit harder by past pandemics. So maybe they have different risk attitudes, but it could also be related to different exposure to information, for example, about whether these kind of routine immunizations were actually essential service or not. That's it for me. Thank you very much.
Thank you very much, Thomas. We have questions now, and there already is a question here, Thomas. That was, what was the reason for only following the children for 9 months? Based on the charts, it looks like the gap would continue to close if they were observed for longer.
It was, first of all, it was a little bit determined by the limited availability of data when we started the project. So now I think we could follow them a little bit further. But second, there's also the problem a little bit with the approach that we are using by comparing these earlier born children and the later born children. And after 9 months, basically, the earlier born children, they also grow into the pandemic. So they are kind of then also affected by the pandemic themselves, which complicates, of course, any interpretation if there are still differences in uptake. But in principle, I think, yeah, it would be worthwhile to look at it, and I think we could do that now.
What were the cohort sizes you were working with?
Different a little bit for different population groups. I have to look at the average effect. So for these like where we look at average effect for the entire population, it was around 26,000 children per event. Of course, when we then look at subpopulations, the sample size increases a lot, and they're only sometimes only 10,000 or 2,500 for specific children from specific people, ethnicities. But I think sample size is not a big issue because basically it's population-wide data, and this is the big advantage of the IDI, that we have relatively large sample size.
I think that was a fantastic piece of work, Thomas. Did you have a sense of the sort of 15 months, sort of they seemed in between? Was that eventually no significant differences with the 15-month vaccinations?
I think in that, like when you look at the entire population, yes, there is no statistically significant difference. But when we looked at these subpopulations, we found this or sometimes we found again for these low SES families children or children from different ethnicities, we sometimes still see differences. So even there seems that catch-up was not complete after 9 months.
Firstly, thank you, Thomas. It was really fascinating and not something I was aware of. Especially the 4 year is really, really big effect. I was intrigued by the birth order effect because Māori and Pacific families tend to be larger. So I wondered the extent to which the big effect on Māori and Pacific was driven in part, at least, by they are more likely to be later born children. And so I just wondered if you stratified, compared Māori and Pacific firstborn versus other ethnic children firstborn and then later born, etc.
No, that's a good point. We didn't do that, but yeah, we could do that and probably should do it to kind of with them within these groups of birth order effect. I can add for this other paper that I pieced with Austrian data. There we look kind of within families even, and there these effects seem to persist. Even when you compare children from the same families, there are these differences in vaccination behavior, which are quite interesting. But of course, we cannot do that here because there are only the pandemic only hits one child per family, so this is we cannot really see. But we can stratify by ethnicity. That's a good suggestion.
There's another question here from Suzanne Jackson. How big was the sample? I believe Thomas has already answered that. I think probably given it was how many months? 3 months, so about a quarter of the birth cohort. So in the order of 20,000.
Yeah, 25,000 because it was basically the control group plus the not affected group. But the sample size varies a little bit, so it's a different sample for each immunization event, of course, and when you look at subpopulation, the sample size is quite low.
And it was interesting to see the different regional differences and the fact that the different regions sort of had different rates of catch-up as well.
Might also be relevant to kind of look at that within ethnicities to kind of see if it's really driven by different characteristics of the population or by different experiences, different policies during the pandemic. So that would also be, I think, interesting expansion.
Yeah. I mean, I think we've already got to the heart of some of the reasons why. I mean, the services just aren't sort of amenable enough, especially with large families and, for rural areas, they're just not accessible enough. So I'm going to finish with Whaeowhia te kete mātauranga, which is fill your baskets with knowledge, which I think we have done today, and leave us all with kia mai tō. So I hope you are leaving with fulfillment today from the talk. Thank you.